Fluids and Electrolytes, presented by Dr. Kevin Pei, Assistant Professor of Surgery at Yale School of Medicine. Please give a warm welcome to Dr. Pei.
Hello. Okay, so this module is on fluids and electrolytes. There's a lot of high yield stuff on electrolytes, so if I speak as quickly as I did during the infection thing, it may just kind of fly by, but it's all in your books, in your syllabus. So review it. This is high yield. Definitely don't ignore the electrolyte section, as annoying as some of it can be. I don't have any financial disclosures. And these are the lecture modules. We're going to talk a little bit about body fluid compartments, fluid homeostasis, how we maintain, we're talking about maintenance fluids and electrolyte therapy, and then we're going to go through the calcium, potassium, sodium, mag, and phosphate disturbances, and then hopefully some useful surgical scenarios. Body compartments, right? So this is like medical school stuff that sometimes I need a little bit of reminder of, which is that most of our fluid is an intracellular component, right? We don't have access to that component. So 1/3 of your fluid is actually extracellular, and 1/3 of that is actually intravascular, right? And so when you do all the math behind it, you end up with about 7% of your total body water is intravascular, right? And 7% of your body weight and that equates to about 5 liters, okay? So that's your total circulating volume. That's the premise behind everything about how much blood you lose and how much of your circulating volume have you lost. This is your normal intake and output, right? So we take in probably somewhere about 1.5, 2 liters, and we put out similar amounts, okay? So our bodies specifically our kidneys are very, very good at trying to maintain this homeostasis. Maintenance fluid and electrolyte therapy, okay? A favorite medical student question, right? While I was rounding with them, I'm always asking them, well, what are our goals of maintenance therapy? Why do we call it that, right? And because people associate maintenance therapy with a specific type of fluid, and that's really not the idea behind maintenance versus resuscitative therapy. Maintenance fluids, all its goal is to replace the ongoing losses of water and electrolytes, trying to get as close to plasma as possible without making the patient hypo or hypertonic. It also provides nutrition, therefore the D5. Remember that when you calculate how many kilocalories per gram of sugar you get, or D5 you get, the D5 in our solutions only affords you 3.4 kilocalories per gram, which is why when you're doing that math and you're going, what the hell, it's not 4, that's the reason, because of our solution. Okay. Volume is approximately 2 liters per day. That's where you get the 84 cc's per hour for an average adult person. Okay, so this is a classic formulation, isn't it? We use this all the time. When our resuscitative period is over, we say, let's put our patients on D5 abnormal saline plus 20 milliequivalents of KCl. We give them sugar, we give them their electrolytes, we give them fluid, and by the end of the day of 2 liters of this, you have pretty close to maintenance of the patient's plasma volume. Here's fluid composition. We mentioned during the I think the trauma lecture on pancreas injuries and how you could have a pancreatic fistula. So this is the fluid composition. The next slide is actually going to be on which fluid component of your body is what kind of a makeup, right? But you see that the reason the surgeons love LR is that it's as close to plasma as we can get in terms of the fluid that's available to us. At the end of the day, it doesn't matter what kind of fluid you give. You can give normal saline, you can give LR. You can give LR with blood, even though that was thought not to be safe. It doesn't really matter. You can give whatever fluid you want. Here's the body fluid composition, right? I just point out to you that, succus or small intestine content and bile is the closest fluid to your plasma concentration, right? Which is why it's so important when you have large volume, particularly small bowel fistula losses, that you try to at least try to maintain those, because those losses, it's almost like you are losing plasma. It is like you're losing plasma. And then the last thing to point out on this slide is that the pancreatic secretions are incredibly high in bicarb, right? Look at the bicarb column, the second to the left, second to the right. This is osmolality. This is how we calculate. And for all the differentiations of one's fluid status as one's electrolyte status with relation to your fluid status, one has to calculate osmolality. These are the major oncotic players. It doesn't account for everything, but they're the major oncotic players. So it's something like 2 times sodium, right? Your BUN over 2.8 and your glucose. Those are major oncotic players. A reminder slide of classes of hypovolemic shock. We got 5 liters. If you lose greater than 40% or 2 liters of that, you're in class 4 shock, is when you really see overt signs of somebody who's in hypovolemic shock, right? And in shock, our goal is initially to volume expand. This is the slide to tell you about how colloid is not better than crystalloid. For a moment in time, we thought colloid was worse than crystalloid. That's not panned out. So frankly, make it really easy. It doesn't matter what you give, as long as you don't give Hespan, which is hyperoncotic starch. Okay, we don't do hyperoncotic starch. And I would also encourage you in clinical practice, after you say good morning to your anesthesiologist for your case, you say, oh, and by the way, don't use any hyperoncotic starch, please, during my case. For sepsis, colloid is contraindicated, and I'll get to that slide in a little bit, all right? Blood component versus whole blood. The military has a lot of experience about giving whole blood. It is not in common practice to give whole blood, right? We always give blood in components. That may change in the next decades, right? But what we know now is if you're giving somebody blood resuscitation, that you try to keep it to a 1:1:1 ratio as close as possible effectively. So that's RBCs to plasma to FFP ratios as close as possible, because you're actually trying to mimic whole blood. That makes sense because the whole blood, we have whole blood, right? We don't have components. Hyperoncotic starch or Hespan, and there's some other brands, it's increased with acute kidney injury and bleeding, neither of which we want in our surgical patients. Starling's hypothesis is an important one, right? It's the balance of oncotic and hydrostatic pressures that determine and regulate fluid balance between your vascular compartments, and specifically vascular compartments that have tight junctions that are not freely permeable to fluid, okay? Now, the Starling's hypothesis or Starling's forces is important because we have clinical disturbances in this intact wall, right? What is that scenario? That's a septic shock patient with the leaky endothelium. That's the patient that you made the incision in. Remember, on the lecture on wound healing, the endothelium becomes increasing permeability, and the reason for that is because it wants to deliver the substrate into the area that requires healing, right? Remember that from wound healing? Well, when you have an increased endothelium and you throw colloid in there, so let's say you put a little bit of albumin into this septic shock patient and their endothelium is open wide. What's going to happen with that colloid? Well, that colloid is going to go into the interstitium, and now it's going to become an oncotic driving force to suck out more intravascular volume into the interstitium, which is why albumin is associated with worse outcomes in septic shock, right? Okay, so then you say, well, what about when you give crystalloid? Well, crystalloid it's very weak. It has almost no oncotic pressure to it, right? It's slightly hypertonic when compared to your blood, but so what? The crystalloid that you give, the bottom line is, at best, a quarter, maybe a third will stay intravascular by the same rules here, right? Especially in septic shock patients when the vascular endothelium is very leaky. Things are just going to go in an interstitium, okay? So I would not use colloid in septic shock. Now, what's the strongest oncotic pressure that we can achieve where I know that when I give this molecule, it's actually going to have enough Daltons that it's going to stay intravascular? Well, it's RBCs, right? RBCs are huge, right? Many hundred times greater than albumin. And so we should give blood to everybody. And so, of course, you are all very familiar already with the literature about how blood is not good and how blood increases mortality. But please remember, a high yield fact for septic shock patients is that if they're not responding to your therapy, we should still try to get their hemoglobin up to, or hematocrit up to 30, all right? So all those rules about it's okay for your patients to sit around 7, one thing has to hold true. Those patients have to be responding to your resuscitative measures, okay? 47-year-old man presenting with bony pain in the back and hips. His calcium level is 15.5 milligrams per deciliter. PTH, parathyroid hormone level is 500. That's high. Hypercalcium can be effectively controlled by 1. Pomidronate, B. Parathyroid analog, C. No treatment is needed because of pseudo-hypercalcemia, and D. Magnesium infusion. Okay. So the answer is a bisphosphonate, which is a pomidronate. That's A. Magnesium infusion, I would give a magnesium infusion, or I give magnesium in somebody who's hypocalcemic and not hypercalcemic. Let's talk about calcium. Okay, so now we're going to go calcium, potassium, sodium, and individual electrolytes. Okay, calcium is dietary. Calcium is absorbed in the intestines. It's very, very well regulated by calcitriol, right, which is the active form of vitamin D. They go hand in hand. Active form of vitamin D is very, very important. And the effective or physiologic functional calcium that we really care about is ionized calcium. You all know that total calcium needs to be corrected for albumin, right, because it's albumin bound. The other idea is this. In a patient who's not stable and you're wondering whether or not their calcium is a reason, one, of course, wants to get an ionized calcium during a code, not a total calcium. Okay? And if your ionized calcium is normal and your total calcium is low, it does not warrant repletion, because right then you only care about the ionized portion. Levels are tightly regulated by the balancing. It's a balancing act between bone resorption, so degradation of bone, and intestinal absorption and the urinary secretion to maintain calcium homeostasis. And when your calcium is either high or low, one of those three things is off. So let's talk about hypercalcemia, right? The hypercalcemia are the, what is the medical student thing that they remember? I can remember it. So I have a hard time remembering things that are supposed to help you remember things. So I just remember these symptoms. So bony pain, renal failure, cardiac arrhythmias, constipation, abdominal pain, neurological consequences, right? And the treatment is one of those three disturbances. One of those three things is disturbed, so you can try to stop whatever the disturbance is, whether it be bone resorption. So if you have a hypercalcemic patient, you want to decrease bone resorption by using something like a bisphosphonate, right? Or you want to decrease intestinal absorption. I'm not recommending that you make the patient vitamin D deficient. And then you can also increase urinary excretion by using diuretics. Okay, so how do we decrease bone resorption? Zolandric acid is an IV infusion. It's one of the best one of the best decrease in resorptions. All of these, by the way, are very similar to similar in action, but it has a risk of renal failure. Bisphosphonate has been our go-to. It's a very classic. It interferes with osteoclastic recruitment. So the osteoclast versus the osteoblast, right? The osteoclast does the breakdown. It can't come to the site, so it can't do its job. But even when it reaches the site, bisphosphonates interferes with the osteoclastic function. Monoclonal antibody. Rankle is a receptor and ligand family for the osteoclastic formation and function. So those cells depend on Rankle for the receptors and ligands, and this monoclonal antibody attacks this group so that you can't even form the osteoclasts in the first place. It's interesting because it's not renally excreted like all the other bisphosphonates, so one has to keep that in mind. Keep that in mind as something that's potentially useful in somebody who already has renal failure. Okay. How do we decrease somebody's intestinal absorption? Well, I said, well, you could render your patient vitamin D deficient, which is not good in septic shock, right? So glucocorticoids, all right? So we give somebody glucocorticoids. So you know the steroid-induced osteoporosis. One of the reasons is because it prevents the activation of the vitamin D, but also it degrades the active form into an inactive form, and therefore, as you know, active form of vitamin D regulates intestinal absorption. So you go through this chain of events, and what effectively ends up decreasing your intestinal absorption. How do you increase urinary excretion? So you give lots and lots of fluid, right? Flush the system out. Calcitonin is something that we can give. But calcitonin, like nitrous oxide, has significant tachyphylaxis, which means you can keep going up the dose to achieve the same amount of effect. Eventually, it will have no effect, right? And then any loop diuretic will also hopefully help you with your calcium. So that's hypercalcemia. visit hypocalcemia. Hypocalcemia has important EKG or cardiac arrhythmia implications. It prolongs your QT interval, right? Hypocalcemia is, the classic thyroid surgery or, parathyroid surgery, and you get tetany from it, calcitrated blood and calcitrated circuits. This is more myth now than anything else, but, calcitrated circuits like dialysis or blood can leach out the calcium, because the calcium and the citrate will bind to each other, which is one of the other reasons why people didn't want us using LR with blood, because blood has calcitrate in it and LR has calcium in it, and so they thought that it was going to crystallize, but it really didn't. Okay. Hypocalcemia, what we really care about is the functional low functional amount of calcium, which is the ionized calcium. All right. And how do you treat this? It's pretty easy. We give the IV calcium gluconate. We give activated vitamin D to increase absorption. You see the pattern, right? If you just remember the 3 things that are wrong. So if you remember the 3 things that are wrong in the system, that's what you attack, those 3 things and disturbances, and you can fix the problem. And you give oral calcium, right? Don't infuse calcium too quickly, because, well, it can induce cardiac arrest. Calcium, by the way, is cardiotoxic for various reasons, and that's why you should be very, very, don't be overly aggressive about pushing calcium during your codes. It really doesn't do anything. Okay, hypocalcemia and sepsis and septic shock. So how does this happen, right? In sepsis, much like in sepsis, a lot of things are relative insufficiencies, but on top of all that, there's also significant insensitivity, like vasopressin insensitivity, right? So similarly, you have a PTH. All sorts of endocrinopathies are associated with sepsis. So you have PTH insensitivity. You also have a decreased active vitamin D, therefore decreased intestinal absorption, right? And you all know that vitamin D is an independent predictor of outcomes for septic shock. Hypomagnesium. Somebody mentioned, the previous question about a magnesium infusion for hypocalcemia. So why is MAG so important? Well, because MAG contributes to PTH, or hypomag contributes to PTH resistance, because MAG is important in a cyclic AMP activation of the effector cell in the PTH level, right? So 125 activation of vitamin D in kidney, that's right, so the calcitriol goes to the kidney and then it adds another OH molecule onto this, so that becomes a 125 form. That's also a process that's dependent upon magnesium, right? So remember, please, on the exam, that if you have a hypocalcemia patient, oftentimes the next step is to replete the magnesium. Patient has Crohn's disease and frequent nephrolithiasis. It's my favorite question. Intestinal absorption of which compound contributes to the nephrolithiasis? A, phosphate, B, calcitriol, C, fat, or D, vitamin E? All right, 81% of you said phosphate. Inflammatory bowel disease-related nephrolithiasis or kidney stones is classically a calcium oxalate stone, all right? And the pathophysiology, or the physiology behind that, is in inflammatory bowel patients, particularly around the terminal ileum, they have a lot of fat malabsorption. That fat binds the calcium. That calcium would have attached itself to the oxalate, so you would have pooped it out. But now, because the calcium is going to the fat, the oxalate is being absorbed. That oxalate then crystallizes in the kidney, becomes calcium oxalate stones. All right? Okay, we are done with calcium. Let's move on to potassium. Okay, potassium. So if you ever forget that potassium is largely intracellular component, all you have to do is look at your chemistries, right? Because your chemistry, your potassium is what, around 4? So clearly it's only measuring what's in the plasma, and it's not measuring intracellular. Potassium must be mostly intracellular. One of the most important drivers of potassium homeostasis is aldosterone. Remember that aldosterone it works in the distal convoluted tubule, right? To the on this picture here, the box is lumen. That's the nephron lumen, right? So what the aldosterone does is it's trying to hold on to fluid. You all know fluid is a passive thing. It follows electrolyte gradients, oncotic pressure, right? So what aldosterone is trying to do is it's desperately trying to hold on to sodium at the expense of potassium, right? So potassium is leaching out, aldosterone causes hypokalemia, okay? And the concept of potassium-sparing diuretic is important because it actually antagonizes the action of aldosterone on potassium. Just because you use a potassium-sparing diuretic doesn't mean that aldosterone isn't trying to do its job either, right? Aldosterone is still out there, and so the potassium-sparing diuretics actually antagonizes your aldosterone, and it antagonizes the aldosterone, so the aldosterone doesn't have the ability to hold on to more sodium, therefore driving more fluid retention. Oh, by the way, you clearly see that there's an electrolyte inequality here, right? We have to have electrical neutrality, otherwise there will be a lot of entropy in the world. And our kidney says, for every anion I get rid of, I also have to get rid of a cation to remain electrically neutral, right? So what other cation do we know of that we need to get rid of, because we're holding on to 3 of sodium, but we're only really getting rid of 2 potassium, right? And that's hydrogen, okay? That's also why you also get the metabolic alkalosis from massive diuresis. All right, hyperkalemia. So hyperkalemia is most likely due to impaired renal excretion, right? There's also transcellular shifting. Acidemia. So you have a patient who's septic shock, lactate of 7, has a metabolic acidosis. You're treating, and then by the way, you say, okay, you got to be careful about this hyperkalemia, right? Because if you use a binder, for example, and you go crazy, you go with a K-exalate, and you go, oh, I'm so happy now the potassium is 4, but as soon as the metabolic disturbance goes away, namely metabolic acidosis goes away, all of a sudden all the potassium goes intracellularly, and now you have profound hypokalemia. So you just want to watch out how aggressive you are trying to get rid of high potassium in the face of metabolic acidosis. Hyperkalemia is also something like tumor lysis or cellular breakdown in the trauma patient, somebody who, I don't know, slipped and fell in their tub and lay there because nobody checked on them and they got rhabdo from it. They have cellular death. All the intracellular potassium now all of a sudden becomes extracellular, and that adds to your plasma amount of potassium. Potassium is largely interested. It's largely interested in the potential cardiac manifestations. So when you see hyperkalemia, the first goal is actually not to just get rid of the potassium. Is to do what? Is to stabilize the myocardium, right? Okay. So sort of just maybe commit these to memory. That hyperkalemia, everybody remembers the peak T's, but we sometimes forget about the shortened QT interval, the widened QRS. The shortened QT interval and the widened QRS all contributes to your progression to ventricular fibrillation, right? We can see that. You've gone to a wide complex arrhythmia, particularly a tachyarrhythmia, and a shortened QT just means that your heart is even more excitable than baseline. Okay. Treatment of hyperkalemia. Priority number 1 is to stabilize the myocardium. You know, if you were in a cartoon world and you can only do literally one thing at a time, you would do stabilization of myocardium first. Okay. Clearly in real life we do all sorts of the whole shebang at one time. We want to redistribute the potassium by stopping the metabolic acidosis by giving somebody bicarb and trying to neutralize, not to make them metabolically alkalemic, and then to excrete the excess, right? So how do we do that? We give calcium gluconate to stabilize the myocardium. We give bicarb to increase the pH to drive potassium intracellularly. Insulin does the same thing. Dialysis and binders get rid of potassium, right? If you have a patient who's already dialysis dependent, never mind everything, all the other stuff. Give them the calcium and then go to dialysis right away, all right? Okay, hypokalemia. Again, transcellular shifting contributes to this. This time, metabolic alkalosis contributes to this, right? There are some times where you have hypokalemic patients on the ward, and you continue repleting potassium 20 milliequivalents at a time, or 10 if you have a peripheral, and you say to yourself, why isn't this number coming up? And that's because, unfortunately, the plasma amount that you get into chemistry is actually not reflective of where it's mostly stored, right, in the intracellular component. So if you find yourself dumping potassium in and the plasma concentration is not coming up, all that means is that you're far lower than what your intracellularly than what your lab represented. Hypokalemia, just like hyperkalemia, contributes to the excitability and the depolarization stability of your heart, and therefore causes excitability in your heart and an attenuated depolarization in other muscles. What does that mean, right? It can end up something like weakness or rhabdo. Any organ system that requires muscle function can be weakened as a result of your hypokalemia. And here are the EKG changes, right? So, very distinct compared to the hyperkalemia. We have somebody now prolonged QT interval. We have depressed T waves, and the U wave is a component of this excitability component. Now, if you also have low magnesium, these are patients, hypokalemic, hypomag patients, are set up for torsades, right? We don't like to see torsades. And if we see torsades, the first treatment is to do what? Is to give mag, okay? When you see torsades, the first treatment is to give mag, because hypokalemia in and of itself does not induce torsades. Now, the question is, if a patient has metabolic alkalosis and is hypokalemic, what do we do? Any ideas? If your patient has metabolic alkalosis and hypokalemia, what do? Well, we do the same thing. We replete them, right? We replete them, but we're not going to give them acid. We're not going to give them acid to replete the metabolic alkalosis. The other thing to remember is that if your metabolic alkalosis and hypokalemia is diuretic induced, particularly loop diuretics, you're going to need to give lots and lots and lots and lots of potassium before that metabolic alkalosis is corrected. The other thing to be careful about is if you're going to replete lots and lots of potassium, as soon as that patient is no longer metabolically alkalemic, there's transcellular shifting of potassium outward into the plasma, right? So now you got to be careful, because now all of a sudden you've over repleted and the patient becomes hyperkalemic. Sodium. Okay. As you remember from the osmolality equation, sodium is a major player. It's a major player in terms of water homeostasis. Water doesn't have a mind of its own. It just follows whatever gradient that you achieve. All right. Sodium is a major determinant of water homeostasis, not volume. All right. So for all the times when you say, well, the patient is hyponatremic because they're volume overloaded, that's not necessarily true. In fact, most of the time that is not a true statement. Okay. All right. Normal sodium means that there's good balance between free water and sodium, but it doesn't mean that you're euvolemic either. So both sides sort of doesn't work, right? Volume doesn't necessarily reflect sodium level. Sodium doesn't necessarily reflect your volume level. But if you have a normal sodium level, all that means is that your body has gotten control of the sodium in relationship to free water ratio. And that's important for when you evaluate why somebody may have disturbances in their sodium level. So how do I determine somebody truly has a hyponatremia or hypernatremia for that matter? Well, I want to make sure that I want to calculate their osmolarity or osmolality first, right? If you have a hyperglycemic patient, for example, for every 1.6 milliequivalents sodium drop, for every 100 grams of per deciliter of sodium increase, you're going to get a 1.6 milliequivalents per liter of sodium drop. So you got to correct for somebody who's in a DKA, for example, that might have a hyponatremia. But if you truly have a hypoosmolar hyponatremia, then we're going to look at the volume status, and this is where volume status is very important. Okay, this is an important slide. It's a little bit busy, but to remember that once you've diagnosed somebody with true hypoosmolar hyponatremia, you look at their volume status. This is difficult because when people came up with these things, when nephrologists came up with these sort of decision trees, the way that you were told to decide what the patient's volume status was, you're supposed to walk into the room and just look at the patient and see what their volume status is, right? And so, but of course, since these decision trees have come out, we recognize that looking how edematous the patient is has no really bearing on what their intravascular status is, and that's what we really want to know, right? But for now, this is the best we got, okay? Hypovolemic hyponatremia patients are incredibly easy to fix. You just give them saline because their system is trying to hold on to water so much that it's and you know that the antidiuretic hormone system doesn't hold on to water, right? But it holds on to sodium. And so what happens is that the water comes back because it's so desperate to try to hold on to this water that it overwhelms it. And now you have a free water to sodium proportion that makes it when you measure it, it has become hyponatremic. Okay. Now let's talk about the euvolemic patients, right? The euvolemic patients is where I put SIADH. That's the only one that I want you to remember is symptom of inappropriate antidiuretic hormone. I would argue that 90% of patients with hyponatremia in the hospital, while not completely a diagnosis of inappropriate antidiuretic hormone, pretty much all have a diagnosis of symptom of inappropriate antidiuretic hormone. Well, why do I say that? The reason I say that is because whether you're hypovolemia or euvolemic and you're hyponatremic, the reason you're hyponatremic is because there's an inappropriate amount of ADH circulating around. All right? And then the other thing I want to point out just to remember is cerebral salt wasting, right? So the traumatic brain injury patients, cerebral salt wasting is defined by hypovolemia. Okay, so you cannot have a euvolemic patient with cerebral salt wasting. That patient is a hypovolemic patient. Okay, prognostic factor. Sodium is a very important thing. We talked about how it's a prognosticator for necrotizing soft tissue infections. It's important in sepsis. It's important in small lung cancer. It's also an important prognosticator for liver disease and cirrhosis. Okay, so functional hypovolemic hypoeuvolemia. This is the easy one, right? Because that means the patient has true decrease in the volume due to hypovolemia. This is the patient population that has the hepatorenal syndrome or the CHF patient, where they're what? They're chronically the heart failure in the cirrhotic patient whom tissue perfusion is reduced because they have a low cardiac output or arterial vasodilation. Okay, so this is an important patient population to remember where you have hyponatremia and it's associated with cirrhosis and heart failure. So let's do a question. So decrease in circulating volume results in increased capillary permeability to facilitate hydrostatic pressures, increased ADH, narrowing of the pulse pressure, decrease in the afferent glomerular filtration, and subsequent negative feedback loop on the renin-angiotensin cascade. It's fantastic. Okay, so decrease in circular volume, exactly right. Increase antidiuretic hormone. These are regulatory responses to hypovolemia. It acts on all the common pathways to increase antidiuretic hormone secretion, right? The carotid sinus senses that there's hypovolemia. The afferent arteriole senses that there's decreased incoming pressure or flow. The stretch receptors in the heart senses that there's decreased filling. And all that says, oh, I probably in hypovolemic, I'm going to do ADH. Okay. For CHF and cirrhotic patients, these are actually both volume overloaded states, right? And in cirrhosis, that's due to arterial vasodilation, particularly in the splanchnic beds. In CHF, the carotid senses low flow, right? So remember back a couple of slides, all the mechanisms that senses hypovolemia, but these patients aren't hypovolemic, and yet they're physiologically hypovolemic to our body's mechanisms of detecting hypovolemia, because functionally a cirrhotic, for example, doesn't have enough circulating volume. They just have a lot of static volume. CHF patients don't have enough cardiac output, and so therefore the carotid sinus says, oh, I must be in a hypovolemic state. And both, again, lead to antidiuretic hormone. You see the vicious cycle. You hold on to more fluid even though you're in a hypovolemic state, right? SIADH. So SIADH is not suppressible with water ingestion, okay? And this is one of the euvolemic scenarios if you go back to the decision tree. It's related to trauma, small cell lung cancer, surgery, stress, right? Common scenarios to remember, all right? And if you were to get urine studies for SIADH, you would see concentrated urine, right? Inappropriately concentrated urine for that matter, because why is your urine concentrated when you have hyponatremia? It doesn't make any sense, right? The treatment for it is dimethylcycline, which is actually used to be an antibiotic. It acts on the collecting tubule. Okay, it makes the collecting tubule less responsive to antidiuretic hormone, all right? And it's an antagonist of vasopressin. Okay, cerebral salt wasting, we talked about this already. Its ADH release is in response to low intravascular volume. That's why it's grouped into the hypovolemic group. All right, let's do a question. 32-year-old man sustaining diffuse axonal injury, subdural hematoma with an ICU day, who's on ICU day number 1. Found to have profound hyponatremia at 125. Patient developed seizures after rapid correction of sodium. The next appropriate management step is call the transplant team, EEG for its potential status, stat CT of the head, and continue hypertonic infusion. Stat CT. Okay. All right. Great. So, and some of you said continue hypertonic infusion. So good for all of you, because what you recognize here is that rapid correction of sodium in an acute setting does not cause demyelination. All right. So excellent, everybody. Okay. Now, difference between stat CT versus hypertonic infusion. I suppose the reason that we're looking for stat CT is because one doesn't want to assume that it's a sodium-related event, right? What if the patient had a blossoming of a subdural, or something else is happening inside the CT, inside the head that requires more rapid management. Good. So correction of hyponatremia, if in chronic more than 72 hours, some will say 48 hours, the daily rate is the single most important determinant of demyelination, all right? CPM, it used to be called. Now it's called osmotic demyelination syndrome. We want to limit it to about 9 to 12 milliequivalents per liter in the first 12 hours or 24 hours. So you don't want to correct it faster than that. Which essentially equates to about 0.5 milliequivalents per hour. All right. Osmotic demyelination syndrome, formerly known as CPM, it's due to rapid correction of chronic hyponatremia, not acute. And the reason for chronic is because there's been chronic adaptive mechanisms that finds new equilibriums. All right. In acute, there's not been enough time for homeostasis, so it doesn't really matter. There's no cell shrinkage, there's no apoptosis, so you can correct it, and in fact, you should correct it quickly. Right. Osmotic demyelination syndrome has this locked-in look, right? Patients become dysarthric, dysphagic, paraplegic, or quadriparetic. There are behavioral it's very difficult sometimes to diagnose this. Thank God it's very, very rare. But if your patient is not behaving in the way that that you expect them to neurologically, or that their exam is not consistent with their imaging findings, have this in your back of your mind, particularly if you recently corrected sodium. Right? The diagnosis based on MRI and a high index of suspicion. And unfortunately, there's not much you can do about it. It's all supportive care. Many of these patients progress to brain death. Special risks include alcoholics, malnutrition, liver disease, hypokalemia, hypoxia. Again, I think what it does is all of these things really primes your cells, number one, for some sort of a deranged homeostasis, and it's primed, particularly the hypoxic patients, primed for apoptosis. Hypernatremic patients, specifically we're talking about diabetes insipidus, right? Whether it's central or nephrogenic. We just took care of a patient with a TBI that peed out 4 liters a day and had a specific gravity in the urine of 1, right? Clearly that's a DI picture. And what ends up happening is that they have an osmotic diuresis that's autoregulated. Okay? It results in significant dehydration. This is that picture of a patient who is hypovolemic hypernatremia. And the rationale for treatment of this is that if hypernatremia develops very, very rapidly, you can start getting neurological deficits. Just like hyponatremia, chronic hypernatremia needs to be corrected slowly, right? It's just the opposite of the homeostatic processes that happen with hyponatremia, but nevertheless, there has been homeostasis, and if you correct it too quickly, you can still get the very similar brain swelling and demyelination. Magnesium, phosphorus. All right. So again, magnesium is mostly intracellular. It's so important that if you have a patient as a scenario that has hypocalcemia, I would reach for the magnesium as the answer. All right? Magnesium has intestinal absorption, and it's renally excreted. It's cofactors to many, 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 many important things, including, remember, the Torsades picture, right, in a hypokalemic patient. Okay. 26-year-old woman with who is peripartum, with peripartum hypertension and elevated liver enzymes. You also should be familiar with that syndrome. who sustains tonic seizure postpartum and is treated with magnesium and hydralazine. Patient is difficult to wean from the ventilator with poor rapid shallow breathing index. Laboratory testing should include AST, ALT, beta-HCG, or magnesium. Fantastic. All right, everybody got magnesium. It's that magnesium infusion that causes this flaccid state, right? So hypermagnesium, it's important but rare scenario. We're talking about eclamptic patients, HELP syndrome patients. What you end up with is you have a neuromuscular disturbance, and specifically you prevent the presynaptic release of acetylcholine, right? Okay, and so as a result of the decrease in the acetylcholine, decrease in deep tendon reflexes. So much so that our gynecology colleagues do what? They check deep tendon reflexes on somebody who has a magnesium infusion in place. And by the way, they drive their magnesium really, really high for their eclamptic patients. Hypomagnesemia. All right, so hypomagnesemia behaves very much like what? Hypocalcemia. All right, hypomagnesemia and hypocalcemia to me are easy to remember if you just remember one and the other. It causes tetany, arrhythmia, seizures. It's frequently associated with basically all the other hypoelectrolyte disturbances. It causes cardiac excitability. And as just a rule of thumb, at moderate degrees, your EKG changes look like hyperkalemic. At severe degrees, your EKG looks like hypokalemic. So it really can mimic both, right? And again, we go back to the idea of torsades, okay? It's an important cofactor for all ATP-dependent pumps. So if you need ATP for it, you need magnesium for it. And that's why we replete magnesium in our postoperative patients. Phosphatemia, hypophosphatemia, okay? Just like magnesium, well, although magnesium is a cofactor for ATPases, phosphate is right in there in the name, right? So it's the phosphate is important for all functions that require ATP, right? So if I were to ask you what are the side effects of hypophosphatemia, you can pretty much go head to toe, and every disturbance you can find is related to hypophosphatemia, as long as it's an ATP sensitive process. All right. This next bullet point is very important. Okay. Red cell 2,3-DPG. This is the rationale behind not wanting to use old blood, right? We're challenging those sort of paradigms all the time. But the rationale for not wanting to use, one of the rationales for not wanting to use old blood is because red cells that are stored have decrease in their 2,3-DPG. And that's a conformational change. The 2,3-DPG increases the affinity of hemoglobin for oxygen. Now, why is that bad? Okay, so 2,3-DPG controls a conformational change, and if you have a drop in this 2,3-DPG, it increases the hemoglobin's affinity for oxygen. Why is that bad? Well, if you're trying to deliver oxygen to your tissue level, and you're giving old blood to use the old blood to do it, well, the hemoglobin is going to hold on to the oxygen. Boy, is it ever. It's going to hold on to it with more affinity than new blood, right? Problem is, it gets to the peripheral tissue, and it's not going to unload the oxygen that you just deliver there. That's why old blood is bad. Okay, so old blood equals decreased 2,3-DPG equals conformational change equals increased affinity for oxygen for hemoglobin for oxygen and decreased delivery. Okay, all right. Hypophosphatemia. All right, so hyperphosphatemia. All right, so you look at all those three things. It's like the lethal triad. It's got to be a perfect storm. You have a decrease in vitamin D production. You have it precipitates calcium, right? Calcium phosphate, and interferes with parathyroid-mediated bone resorption. So what does that all those things lead to? It leads to life-threatening hypocalcemia. Right? So it's something. Hyperphosphatemia and hypocalcemia are linked. We're almost there. I wanted to go over some surgical scenarios because, you talk about electrolytes at a lecture, and it's just like so much to try to remember. But as you know, electrolytes and trauma and surgical critical care are just favorite topics of standardized examinations. All right? Here we go. 45-year-old woman with septic shock from an ectopic pregnancy undergoes emergent intubation for worsening oxygenation. Rapid sequence intubation is performed with ketamine. Emergent exploration is performed with adequate evacuation of point of care, products of conception. Despite source control, patient has persistent hypotension on norepinephrine and vasopressin. You expect what kind of electrolyte abnormalities? This is a bit of a toughie. Okay, great. So 47% of you got this. 41% of you were very close. So what are we getting at here? Another multi-step decision tree, isn't it? You recognize, so you read this whole thing and you're going, this is one of those scenarios I was talking about in the last several lectures ago when I said, you read this whole thing and it's not even asking you what you thought it was going, right? So if you just read the prompt, the answer choices, you go, oh, okay, it's looking for something that will cause electrolyte disturbances, right? So now you go back to the question and you say to yourself, okay, the patient, why do they mention ketamine? Because it causes adrenal insufficiency. And ketamine causes adrenal insufficiency, and adrenal insufficiency then is related to what kind of metabolic disturbances, hyponatremia and hyperkalemia. And I apologize, that's what probably screwed everybody up. It should say etomidate, not ketamine, all right? So rapid sequence intubation, I apologize for that. Okay, so the multi-step here is the rapid sequence intubation should have been performed with etomidate. All right, so the etomidate causes the adrenal insufficiency, and the adrenal insufficiency then leads to hyponatremia and hyperkalemia, right? So, sorry, correct that in your slides. Okay, next question is a 45-year-old woman with septic shock from an ectopic pregnancy undergoes emergent intubation for worsening oxygenation. Again, so this one's corrected. It's rapid sequence intubation is performed with etomidate, same thing. Despite source control, patient has persistent hypotension. Next step in management is? Great. So now you recognize, so this is the next step in management. Now, if the prompt were correctly worded, if the prompt said this patient had rapid RSI with etomidate, subsequently had persistent hypotension, what is the next step in management? And it asks you for your electrolyte disturbances. That would be one of those complex multi-step questions. So just be prepared to recognize both the electrolyte disturbances as well as treatment for adrenal insufficiency in any which way it's presented. So the way the etomidate inhibits, the rationale behind etomidate causing adrenal insufficiency, its ability to inhibit 11-beta hydroxylase, right? Remember that that enzyme is necessary for cortisol, aldosterone synthesis, okay? Adrenal insufficiency secondary to hypoadrenalism, right? So remember that picture with the aldosterone that promotes sodium retention and potassium excretion? Well, if you have decreased aldosterone, then all of a sudden you got sodium excretion and potassium retention, okay? So you end up with hyperkalemia, hyponatremia. Decreased cortisol levels increases your CRH, which then also increases your ADH, all right? This is just a high yield, kind of not trivia, but high yield fact to say if a patient, you get a clinical scenario, you read the scenario and you say, oh, my diagnosis is adrenal insufficiency. And then the question says, what do you expect the ADH level to be? Or what do you expect the CRH level to be? That's where this comes from. So you can map it out and figure that out. All right. A 32-year-old man with chronic pancreatitis undergoes a splenectomy for traumatic injury. Postoperative course, he has persistent abdominal pain, nausea, fevers. The CAT scan shows a large left subdiaphragmatic collection. Interventional radiology drainage shows an amylase that is 3 times the serum level. The expected electrolyte and acid-base disturbances is? All right, so this is a little tougher again because it's so many multi-steps. So you recognize that the standard definition of a pancreatic fistula is a level of drainage that's 3 times the amylase level in the drainage is 3 times the serum level. Okay, so number 1. So now you have a splenectomy with pancreatic injury and a pancreatic fistula. You then go back to the idea of the pancreatic fistula. Remember that slide way back that showed you what the pancreatic output would be? It's very, very high output in terms of bicarb. So you have a significant amount of bicarb loss. We need electrical neutrality, right? So we end up with a hyperchloremic metabolic acidosis. How about this question? 68-year-old man with known villus adenoma, another classic presentation to medicine service with copious watery stools. The likely electrolyte abnormality include elevated bicarb in the plasma, hyperchloremia, contraction metabolic alkalosis, hypomagnesium. That's fantastic. All right, contraction metabolic alkalosis. By the way, the villus adenomas are classically copiously watery secretions. What is the electrolyte that it's very, very heavy in? Chloride, right? Okay, so that's why hyperchloremia is not going to be the correct answer. So absolutely, this is a simple volume loss issue. You're having a contraction, copious amounts of diarrhea. You're going to have a volume loss issue. All right, villus adenomas of the colon usually produce a hypochloremic metabolic acidosis because of the large volume of colonic fluid. Right, it's rich in potassium and it's rich in bicarb. Now, 10 to 20% of these tumors will secrete chloride rather than the bicarb with potassium. And that's how you end up with this metabolic alkalosis that is not compensated. All right, next scenario. Just a question. Old blood greater than 2 weeks results in, so columns about ups and down on 2,3-DPG and oxygen unloading. Great. Decrease 2,3-DPG and decrease oxygen unloading. We rewarded it a little bit just so you had to think an extra step, right, as opposed to oxygen affinity. Okay? All right. This is the hemoglobin dissociation curve, right? Hemoglobin dissociation curve. As you move to the left of that curve, what it's doing is that you're having increased affinity for your oxygen to bind to your hemoglobin and not let go. Put a different way, as you move to the left on the x-axis, you have decreased oxygen unloading. That's not good for us because we want that oxygen to unload. We want it to unload very easily, right? So maybe also remember these things that get affected. Remember carbon monoxide does what would carbon monoxide do to this curve? Would it go to the left or go to the, yeah, that's right. Some people were pointing to the left, right? Carbon monoxide increases the affinity of oxygen increases the affinity for not only itself to hemoglobin, but also whatever oxygen is bound to the hemoglobin, so it doesn't unload the oxygen. So it's not purely a competitive issue. It actually does a conformational change where it does not unload oxygen. All right, 43-year-old woman, 1 month status post laparoscopic Roux-Y, gastric bypass. She presents with significant numbness and tingling, and etiology is vitamin D deficiency, hyperphosphatemia, inadequate fluid intake or sequestration of vitamin C. We probably have a few bariatric surgeons in the audience. Great. Vitamin D deficiency. Also, vitamin D is vitamin D a fat dependent? Yeah, good. So the answer is yes, just for the video here. So next question. 70-year-old man, 3 days post coronary artery bypass grafting, has been placed on a Lasix drip or a furosemide drip as the patient is 15 pounds over baseline weight. Common scenario. The expected electrolyte and acid-base disturbances after this chronic loop diuretic drip is hypokalemic metabolic alkalosis, right? So I want to get through the rest of the slides, but if you just, if you go back, you can literally just Google renal physiology about where Lasix works, and you'll figure out why it becomes a hypokalemic metabolic alkalosis. Oh, actually, that is the end. All right.